Okay, so we will start from where we left. Okay, question number 26. Okay, which of the following laboratory abnormality is most likely present in this patient? Start from the last line, then read the options. Elevated amino acid, gastrin, glucose, metastatin. Then start reading from the top. Okay. So first try to find all the abnormal things in this patient, okay, and then try to make a diagnosis out of that. Okay. So what are the abnormal things in this patient? A painful rash involving her groin and legs that has been worsening over the last 2 weeks. Diabetes mellitus, rash, diabetes mellitus, okay. Occasional loose stools, okay. Diarrhea, diabetes, and rash, okay. Okay, so what's the characteristics of that rash? That rash is erythematous, plaques with crusting and scaling at the borders and the central areas of brownish induration, and superficial necrolysis as well. Okay, it is a necrolyting erythematous rash, and the patient has has diarrhea as well as has the diabetes mellitus. Okay, so do you know in which of these disease can you find a rash, a diabetes mellitus, and diarrhea? Out of all these out of all these options, which option can explain all these three findings? There are three abnormal findings in in this patient: a rash,
Elevated glucagon.
yes, elevated glucagon. Okay, so so that specific rash is much more consistent with glucagonoma. Okay, in that you are going to see a necrolyting migratory erythematous rash.
Erythema.
Okay. Okay. In glucagonoma, there are 6 Ds. The first D is dermatitis. Necrolytic, our rash is necrolytic. Migratory, erythema. Our rash is erythematous. Okay, diarrhea, diabetes. Our patient has diabetes. DVT, declining weight, depression, and diarrhea. Okay, our patient has diarrhea. Okay, there is only one finding, there is only one option in this, or in whole of these options which can explain these three findings in this patient. Okay, necrolytic migratory erythema, erythematous papules and plaques, diabetes mellitus, diarrhea, abdominal pain. Let's move on to the next one. The underlying mechanism for this patient susceptibility to fracture is most likely to cause which of the following additional manifestations? Okay, always read the last line very carefully. Okay, sometimes the thing which is mentioned in the answers is right, but that option he is not asking about. Okay, you have to answer specifically regarding the last line. Okay, the underlying. Okay, read the options. Now try to make the diagnosis. 40-year-old woman, first see all the abnormal finding in this patient. Okay, 40-year-old woman, femoral neck fracture, is hospitalized due to femoral neck fracture that occurred when she slipped while stepping out of a bathtub. Okay, the patient was diagnosed with prolactinoma 3 years ago during evaluation of amenorrhea, but she refused medical or surgical treatments. The tumor is being monitored closely and has not increased in size or caused any visual symptoms. Okay. Okay, so the patient has prolactinoma. Okay, so what happens in prolactinoma that leads to increased susceptibility to fracture? What happens in prolactinoma that increases the susceptibility of the patients to fracture?
Amenorrhea occurs in the prolactinoma, and there
Yes,
is deficiency of the gonadotropins, and vaginal dryness is the answer.
yes, because a prolactin inhibits the secretion of GnRH, and when GnRH is going to be low, FSH and LH are going to be low, and when FSH and LH are going to be low, what will happen to the the testosterone levels? They
It will
are
be low.
also going to be low. Okay, and we know when in females after menopause, when they have less estrogen, they are much more prone to get osteoporosis. Okay, because now due to prolactinoma, due to prolactinoma the estrogen production has stopped, because prolactin has stopped GnRH, and GnRH, due to GnRH, FS and LH production is stopped, and due to which estrogen production is stopped. Okay, prolactin inhibits GnRH. Okay, and GnRH is responsible for FSH and LH. Okay, so when a so the increase the in this patient the increased susceptibility to fracture is due to low estrogen, right? So the underlying mechanism for increased susceptibility to the fracture in this patient is low estrogen. Now you have to see which other thing is due to low estrogen. Vaginal dryness. Okay, stomach ulcers can occur due to increased gastrin levels, kidney stones, increased parathyroid hormone, hand tremors, increased thyroid hormones. Okay, okay. Let's move on to the next one. Which of the following is the most likely cause of this patient's symptoms? Okay, let's see the options. The question. 43-year-old woman due to episodic confusion, episodic, blurred vision, tremors, and sweating. Okay. The episodes have increased in intensity in the past few months and seem to occur any time during the day. Our symptoms are relieved by drinking orange juice. Okay. During a recent episode, the patient blood glucose level was 32, low blood glucose. Okay. Medical history includes major depression and irritable bowel syndrome. Okay. Laboratory studies performed during the next episode of symptoms show the following results. Insulin was high. C peptide was also high. Glucose is low. Which of the following is the most likely cause of this patient's symptoms? Okay.
Insulinoma.
Okay. So, okay, if I said B is the right answer, if I said B is the right answer,
No,
so
because it's
peptide would be
yeah,
less.
yeah,
C peptide
because
would be
if
less.
for B to be the right answer, C peptide should be less, right? Okay, and in somatostic, if I say C is the right answer, then what change I should made in this question? If C is the right answer, what is the relationship between somatostatin and insulin? What is the relation between somatostatin and insulin?
Statostatin
It
now
inhibits
is
the insulin
It
secretion.
decreases
Yes,
insulin.
So
somatostatin
we have the
decrease the
options.
insulin levels, not increase the insulin levels, right? Okay. Alpha cell produces which hormone?
Glucagon,
glucagon.
Glucagon. And which hormone is elevated in this patient?
insulin.
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 Okay. And insulin is produced by the beta cells. Now we are left with two options, D and E.
D.
Sulfonylurea
Yeah.
use and DIP secreting trimmer. Which one is going to be the right
The
answer?
sulfonylurea is stimulate the insulin secretions, no?
Yes,
Yes.
Endogenous.
sulfonylurea, because sulfonyl, what is the mechanism of action of sulfonylurea?
It
It
secretes
increases,
the
Potassium channels is blocked.
potassium.
Potassium channel.
Exactly.
it closes the potassium channel in pancreatic beta cells, cell depolarize, and it increases the
Calcium.
insulin release, where increased calcium influx. Or because it is endogenous insulin which is releasing, we know whenever this endogenous insulin is secreting into the blood, C peptide is also going to be secreted with the insulin whenever the insulin is endogenous, and sulfonylurea increases the endogenous insulin levels, not there is no exogenous insulin. Okay, whenever the insulin is made in our body, it is made with a C peptide protein. Okay, so if the cause of increase insulin is endogenous, you are going to see increase C peptide levels. Both both insulin and C peptide are in endogenous insulin, whereas exogenous insulin lacks the C peptide, helps to differentiate factitious hypoglycemia. Okay, so in this question you can clearly see that the C peptide levels are elevated. That's why option number B is not the right answer here. Okay, and or the
Doctor,
symptom episode, yes.
can you please repeat that because I didn't understand?
Okay, so whenever insulin is made inside our body, okay, so when insulin is made inside our body, there is a protein attached to insulin. That protein is C peptide levels, C peptide. Okay, and when the insulin is secreted by the beta cells, they secrete insulin along with C peptide. Okay, and if you want to find out whether that insulin is whether that insulin that is high in your blood is endogenously produced, or is it or is it administered from the outside of the body. So to differentiate that, you have to measure the C peptide levels. If the C peptide levels are elevated, that means that insulin is endogenously made. Or if they are less, that means that the person is taking insulin from outside. Okay, because some people use insulin, some people abuse insulin use. Okay,
Okay.
okay, both insulin and C peptide are increased in endogenous insulin, while exogenous insulin lack the C peptides. Okay,
Okay.
okay, because there is first is pro insulin. Cleavage of proinsulin result in insulin plus C peptide. Insulin plus C peptide is equal to proinsulin. Okay?
Okay.
Okay. Let's move on to the next one. Metabolic changes in which of the following organ are most likely responsible for this patient recovery?
I don't see your screen, doctor. I don't know what happened.
We
Can you
can.
people see your screen, see my screen or not?
No, we
Yes,
can
we
see
can.
it. We can see it.
Okay. I think so. It's your individual issue. I don't know why you are not able to see my screen, because all the other people can see my screen.
Yes, visible.
Okay. A 24-year-old man diagnosed with diabetes mellitus 2 years ago is brought to the emergency department after a temporary loss of consciousness. He was getting ready to eat and administered a preprandial insulin injection, but he was distracted by a phone call from Vic and ended up skipping the meal. Okay. So he has taken the insulin injection, but after the insulin injection, he does not take, he skipped the meal. Okay. And due to which he lost the consciousness. His girlfriend found him passed out in his bedroom and administered glucagon immediately. Okay. The patient recovered consciousness within 15 minutes. Okay. How does glucagon recovers the how does glucagon increases the glucose level?
Glycogenolysis.
Gluconeogenesis
By glycogen, the
Glycolysis
biggest store of glycogen in our body is
in the liver.
liver. Liver is the biggest store of glycogen in our body, and because gluconeogenesis usually take times. Okay, so in the early phase, the increase in the glucose level is due to glycogenolysis. Okay, and we know the biggest stores of glycogen in our bodies are in the liver. Okay, he is asking us how the glucagon recovers the glucose level in this patient. Okay, by glycogenolysis. Okay, let's move on to the next one. Okay. The option again, the question is regarding congenital adrenal hyperplasia. You can see it from the options. Okay, see in this question, by seeing the options, you have come to a conclusion that the question should be regarding congenital adrenal hyperplasia. Okay, it is regarding some type of enzyme deficiency, and that enzyme deficiency is regarding congenital adrenal hyperplasia. Okay, so that's why by reading the last line you will get to solve the question much more fastly, and you did not need to read the question again and again. Okay, so the patient has irregular menses. Narcosis at age 12. Cycles have been irregular, often with multiple months between menstrual periods. The patient has an increased in hair growth along her chest. Okay, increased hair growth. That means the patient has increased androgenic hormones. Okay, okay.
Autism.
These terminals here above the patient and nodulistic acne or the okay. Okay. Sexual staging in ultrasound that reveals a non-nuclear electron. Okay. 17 hydroxyprogesterone is elevated. Okay. So do you people remember that mnemonic? If it starts with one and if it's yes. Okay.
Hypertension.
If the deficient enzyme starts with one, it causes hypertension. If it's end with one, it causes virilization. Okay, our patient has virilization, right? Okay. Now tell me out of these three, which two has virilization symptoms? If it's end with one,
21.
which one is ending with one?
21.
21 and 11.
Both.
Okay, so in these two, we are going to see virilization. Okay, in the question okay. Now to differentiate between these two, he has also given 17 hydroxyprogesterone levels. Okay, he is saying that 17 hydroxyprogesterone levels are elevated. Now we have to see 17 hydroxyprogesterone levels are elevated in which one? 21 hydroxylase or 11 beta hydroxylase. Okay, 17 hydroxyprogesterone levels are elevated in 21 hydroxylase. Okay, it is clearly mentioned in the table. Okay, so at what reaction is 21 hydroxylase is involved? Okay, it is involved 21 hydroxylase. We are talking about 21 hydroxylase in the conversion of progesterone into 11 deoxycorticosteroid and 17 hydroxyprogesterone into 11 deoxycortisol. Let's find out if either of these two reaction is mentioned in the option. Okay, remember progesterone to 11 deoxycorticosterone or 17 hydroxyprogesterone to 11 deoxycortisol. Okay. Okay. Is any of these two reaction is mentioned here?
Yes. D.
Which
Just
one?
D.
progesterone conversion to 11 deoxycortisol.
11 deoxycorticosteroid. Okay. Okay. 11 deoxycorticosterone conversion. Option number E. Do you know which enzyme is involved in option number E? Testosterone to estradiol.
Aromatase.
Yes, aromatase. Okay. Option number A and B. Which enzyme is involved? Option number A and B.
11.
11 beta
11
hydroxylase. Okay. 11 beta hydroxylase. 11 beta hydroxylase involved in 11 deoxycorticosterone into corticosterone and 11 deoxycortisol into cortisol. Okay. So in upper two, 11 is involved. And the option number E, estradiol is involved. Okay. An abnormality in originating in which of the following is most likely cause of this patient and condition? See the options. Okay. 27-year-old woman, evaluation of infertility. Okay. They are trying to conceive for the past 2 years but have been unsuccessful. The husband recently underwent infertility evaluation, found to have no abnormalities. Menses began at age 13 and her menstrual cycles were regular until the last few years when they began occurring at intervals of 3 to 4 months. She has occasional headaches. Okay, infertility and occasional headaches. Okay. The patient has no prior medication, takes no medication. The patient appears normal and has well-developed secondary sexual characteristic. Okay. Diminished vision in the bilateral temporal visual fields. Okay. So there are 3 symptoms in this patient. Occasional headaches, bilateral temporal visual field defects, and infertility. Okay, bilateral temporal visual field defect you are going to see that defect when at what optic pathway, what area is damaged?
Chasm.
Optic chiasma. What thing is present near to optic chiasma?
Pituitary.
Pituitary gland is present near to optic chiasma. Okay, so when pituitary gland is going to enlarge, it is going to put pressure on the inner side of optic chiasma. Okay, and due to which you are going to see bilateral temporal visual field defect. Okay, and when the so that symptom is explained by pituitary adenoma. Okay, and occasional headaches are due to the stretching of the meninges. Okay, because when the pituitary gland is going to enlarge, it's going to stretch the meninges, and due to which the patient is going to have headaches. Okay, now for the infertility. What type of pituitary adenoma can cause infertility? What is the what is the most common type of pituitary adenoma?
Prolactinoma.
Lectinoma.
Prolactinoma. Okay. See, optic chiasma get damaged, you are going to see bitemporal hemianopia. Okay. You can clearly see this is pituitary gland and this is the optic chiasma. Okay. Optic chiasma and this is pituitary. Okay. 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 Most commonly formed lactotrophs, prolactin, hyperprolactinoma. Okay. We are talking about pituitary adenoma. Okay. Pro, prolactinoma classically present as galactorrhea, amenorrhea, decreased bone density due to suppression of estrogen in females and as decreased libido and infertility in males. Okay, now tell me which one is going to be the right answer here.
Pituitary lactotroph.
Pituitary lactotrophs, because these are the one which produces prolactin. Okay. Okay. Let's move on to the next one. Okay. 16-year-old boy, confusion, fatigue, abdominal pain, experienced thirst, polyuria, polydipsia, polyuria. Okay. Family history is unremarkable. Urine dipstick is positive for glucose and ketones. What is the diagnosis here? Is it type
Type
1 or
1
type 2?
diabetes.
Septic
It
Type
is
ketosis.
1.
that is
Type
type
1,
1.
diabetes.
And glucose and ketones are elevated. That means the patient has diabetic
Yes.
ketoacidosis, right?
Yes.
Okay. Now you have to tell me which one is going to be related to type 1 diabetes mellitus. Okay. Okay, let me open the page for you people. Okay. This is the table. Type 1 and type 2. Okay. Okay. Abdominal fat distribution is related to type 2, right?
2, yes.
Excessive body weight,
Type 2.
Type
Type 2.
2.
type 2. Okay. Out of all these three options, which one is going to be the right answer?
E. E.
E. Because we know that type 1 is autoimmune, right? And for autoimmunity to develop, that means some kind of WBCs are going to be involved, right? And you can see that in type 1, it is an autoimmune T cell destruction. Which cell? T cell mediated destruction. Okay, and on histology findings, you are going to see islet leukocytic infiltrate in type 1, and in type 2, islet amyloid polypeptide deposits. Okay, remember this difference. Okay, so in the question, he has given us different histology findings. Okay, now we have to find the diagnosis of the cancer, what type of thyroid cancer it is. Okay, then have to find a finding which is consistent with that cancer. His medical history is significant for what? Pheochromocytoma. His father died of thyroid cancer in his 30s. That means some kind of genetic component is involved. Okay. Fine needle biopsy. Okay. Do you think of any genetic cancerous syndrome in which there is pheochromocytoma as well as a thyroid cancer?
Men too.
Men too. Okay.
Men,
Okay. Yes. Men syndromes in which there are multiple endocrine tumors. Okay. And here we clearly see there are two endocrine tumors visible, and it is genetic. His father died due to thyroid cancer in his 30, right? Okay. The patient has pheochromocytoma. What type of thyroid cancer we see in men syndromes? What type of
Medullary. Medullary.
medullary thyroid cancer, right? Medullary thyroid cancer is seen in men syndromes, right? Okay. Option number A, we will start with option number B. Option number B will be the right answer for what type of cancer?
Follicular.
Follicular. C. Follicular thyroid.
Hyperplastic follicular hyperplasia with tall cells forming intrafollicular projections. This is for Graves' disease. Okay, this is for Graves' disease. Option number A, branching structure with interspersed calcified bodies. That calcified bodies names are Samoma bodies. We see Samoma bodies in which cancer?
papillary,
Papillary. Papillary.
In the
Meningeal
papillary cancer. Okay. Calcified bodies are seen in the papillary thyroid cancer. Okay. Pleomorphic giant cells. Option number D. Pleomorphic giant cells with occasional multinucleated cells.
Granulomas.
This is going to be seen in
Liquid.
anaplastic. Okay. Which one is going to be the right answer here?
C.
The last,
Which one is going to be the right answer here?
Congo Red C.
C.
C. Yes.
C. Yes.
C is going to be the right answer here. And you can see medullary cancer, medullary carcinoma arises from parafollicular C cells and produces what? Calcitonin. What type of cells? Polygonal cells. In an amyloid stroma, stains with what? Stains with Congo red. Now see the option. Polygonal cells, right? And with Congo red positive deposits. Okay, so what would be the right answer? C. Okay, and for Graves' disease, that option, where it's tall, crowded follicular epithelium, scalloped colloid. Okay, follicular hyperplasia with tall cells forming intrafollicular projections. Okay, let's move on to the next one. Okay. Okay. Brain MRI shows a 4 centimeter multiloculated cystic supracellular lesion, which is bulging into the floor of the third ventricular and base of the brain. Calcifications are present.
It's craniopharyngioma.
Okay. So because this cancer is not mentioned in the endocrinology section, it is actually mentioned in the neurology section. Okay. So what structure is present at the supracellular region?
That is cliff.
What structure is present in the cella tatarsica?
Syllabus.
The pituitary gland, right?
Yes.
Okay, so this cancer is mentioned. Need to find out. Mental center. Strokes, the cancer. Okay. Schwannoma. Pituitary. Okay. most supratentorial tumor. Okay, associated with high recurrence rate. Cholesterol blisters found in a motor oil field-like fluid within the tumor. Okay, it derived from where? From the remnants of Rathke
To
pouch.
this
Remnants
part.
of Rathke pouch. Okay, is a cystic supracellular tumor. Okay, well, you can see there motor oil-like fluid. It is cystic. Okay, which have cholesterol in it. Okay, and it is present on just above the sella turcica. Okay, supratentorial tumor in the children's, and calcifications are also present. Okay, commonly arises from the calcifications are present, cystic, supracellular. Okay, what would be the answer in this case?
B. Rathke's pouch.
Okay. Do not confuse this with the pituitary adenoma. Okay, that's why A is not the right answer here. Okay, in pituitary adenoma, you are not going to see calcification. You are not going to see a cystic mass. Okay, remnants of Rathke pouch. Okay. If left untreated, the patient is at greatest risk for developing which of the following? Okay, now read the question. 43-year-old woman, amenorrhea, first symptom amenorrhea, began having irregular menses 2 years ago. Last menstrual period was 9 months ago. Increased serum prolactin levels, normal TSH, and undetectable beta HCG concentration. MRI reveals a 6 mm pituitary adenoma. Okay, so he has given us the diagnosis. The patient refuses medical and surgical therapy, and she is happy about not having menstrual periods. Okay, so he is asking us if the patient would have the pituitary adenoma, what other symptoms which we are most likely to see in this patient? Okay, okay. Do you think A is the right answer?
No.
Cortical stroke. Okay,
No.
cortical stroke is not the right answer. Okay, so what would be the right answer in this case?
Loss of bone.
Loss of
Loss of
mass.
bone mass.
Bone mass.
Vaginal.
Why C is the right answer?
Osteoporosis.
Due to
Decreased.
osteoporosis, because it is going to
Low level of
inhibit
estrogen.
GnRH levels,
Yeah.
and when GnRH is less, estrogen is going to be less. Okay, so they love pituitary adenoma very much. Okay, let's move on to the next one. Okay. Okay. 58-year-old man, foot wound. Okay, small ulcer on the bottom of his right foot a week ago. Okay, small ulcer on the bottom of his right foot. He's been applying antiseptics but has failed to heal. Failed to heal. Has a 15 years. Okay, history of type 2 diabetes mellitus. Okay. And non-adherent to the medical therapy. Okay. Non-adherent to the medical therapy as well. Okay. Another risk factor, smokes a cigarette daily for 20 years. Okay. 1 centimeter plantar ulcer in the first metatarsal head, under the first metatarsal head. There are no other lesion. The tibial and the dorsal pedis pulses are normal. The tibial and the dorsal pedis pulses are normal. Okay. So do you think B is the right answer?
No.
No.
Temperature is normal.
Yeah.
Okay. Do you think A is the right answer?
No, because pulses are normal.
No.
Yes. But both
Yeah.
the tibial and the dorsal pedis pulses are normal in this patient. Okay. That means there is no atherosclerotic diseases yet develop in this patient in the lower limbs. Okay. That's why the last line is very important, because in diabetes patient you are going to see two types of ulcer. One ulcer is due to arterial insufficiency, and the other ulcer is due to neuropathy. Okay, so people usually get confused whether that ulcer is due to arterial or neuropathy. Okay, so the last line clarifies that the ulcer is not due to arterial insufficiency, because the blood flow is normal in the lower limbs. Okay, other than that the other thing that is important is the location. Okay, arterial and ulcers, I think so it is written in MSK. They have changed the location. It is written in MSK, I think so. The ulcers, oh, here it is, MSK. What is the location for neuropathic ulcers? Bony prominences, metatarsal head, and the heel. And what is the location for the arterial ulcer? Distal toes, anterior shin, and pressure points. Okay, in the question, see the location. First metatarsal head. First metatarsal head. And what type of ulcer develop at first metatarsal head? Neuropathic ulcers. Okay, and they're going to be absent pain. Okay, or and in arterial ulcer, the pain is going to be very severe. Okay. Okay. And the venous ulcer develops in the gator area, and the pressure injury usually as sacrum, ischium, and calcaneus. Okay. So what will be the answer in this case?
Sensory impairment.
Sensory impairment. Okay, because it is a neuropathic ulcer. It is not systemic vasculitis. It is not venous insufficiency. Venous insufficiency ulcers develop at the greater area, at the medial malleoli or the, okay. So sensory impairment. Okay. Arterial ulcers location, tip of toes and malleoli. Venous medial tibia, and neuropathic bony prominence like the head of the first metatarsal or the heel. Okay. Let's move on to the next one. It is written on page number 491. Okay. In MSK. And the ulcer is there will be no pain in the neuropathic ulcer, and the arterial ulcers are going to be very painful, and the skin is going to be hairless, shiny, and cold in the arterial ulcer. Okay. Which of the following is most likely responsible? A 54-year-old man comes to the hospital due to worsening fatigue, generalized weakness, and unintentional weight loss over the past several weeks. Okay, see the options. Now read the question. Okay. Now see all the abnormal findings in this patient. Worsening fatigue, generalized weakness, and weight loss. Okay. No prior medical conditions. 40 pack years smoking history. Okay. Blood pressure is elevated, 160 by 100. Okay. Hyperpigmentation. Hyperpigmentation is also present. They are scattered ecchymosis in the extremities. Okay. Chest imaging reveals a 6 centimeter irregular right lung mass, central right lung mass with mediastinal lymphadenopathy. Okay. Is the ACTH is going to be higher in this patient or lower?
Higher.
Higher. Why? Because we are seeing darkening of the skin.
Yes.
Whenever you are going to see hyperpigmentation, that means ACTH is going to be high. Why hyperpigmentation is linked with the ACTH levels? Why hyperpigmentation is linked with the
From same origin, pro-optomelanin protein.
yes, because ACTH is produced from what molecule?
Pro-optomelanin.
POMC molecule. MSH and ACTH share the same precursor molecule POMC. Okay, so when ACTH will be higher, POMC is going to be higher, and because POMC break down into two molecules, one is MSH and the other is ACTH. Okay, so MSH will automatically be increased. Okay, and due to that increased MSH, you are going to see increased hyperpigmentation. So we are sure that this patient has increased ACTH, right? Okay. Are these symptoms of high cortisol or low cortisol? Are these symptoms of high cortisol or low cortisol? Scattered
High cortisol.
ecchymosis on
High
the extremity.
cortisol.
Yeah, see, the patient has proximal muscle
Proximal
weakness.
weakness.
The
Yes.
patient has skin fragility. There are scattered ecchymosis. The patient has fatigue. Okay. Also, we are sure that the patient has high cortisol and high ACTH. Okay. So that means the main pathology site is not within the adrenal cortex, right? Because
Yes.
if the main pathology is within the cortex, is within the adrenal gland, what how does the pituitary gland will respond to that?
ACTH will decrease.
There will
Yes,
Reduced
be
yes.
ACTH.
ACTH
ACTH.
will
Negative
decrease if the
feedback.
main
ACTH will
pathology site is yes. If the
decrease.
main pathology site is within the adrenal cortex, so the normal response of pituitary will be to decrease the ACTH, right? But in this case, ACTH is higher. That means that the main pathology site is not within the adrenal cortex. Option number E is eliminated. Eliminated. Okay. Okay. Now we are left with A, B, C, and D. Okay. Now we have to see where this ACTH is coming from. Is it coming from the pituitary or is it coming from an ectopic site? Okay.
Ectopic site.
Ectopic site. Why? Because if it is
Imaging.
from pituitary, if you select the answer that the right answer is pituitary, then how can you explain this? Chest imaging reveals a 6 centimeter irregular mass with mediastinal lymphadenopathy. How are you going to explain this finding? This finding can, yes, small cell lung cancer. We know small cell lung cancer do produces ACTH. It also produces ADH. It also produces parathyroid hormone as well. Okay, it do produces this is called paraneoplastic syndrome. Okay, so the answer in this question will be, it is not going to be C, it is not going to be D, no, what is going to be A. Okay, ACTH production from an ectopic site. Okay. What will happen to the cortisol and ACTH on high dose dexamethasone suppression test?
Decrease.
What will happen? Are they going to decrease or no decrease in this patient?
No,
It will not
High dose.
decrease.
In this patient,
Increase. It will not decrease because it's from ectopic site.
Yes, because it is from an ectopic site. In high dose dexamethasone suppression test, they are not going to decrease. Remember this. Okay, this is very important. They do ask questions regarding the high dose dexamethasone suppression test. Ectopic ACTH secretion in high dose dexamethasone suppression, no decrease. No decrease. If the ACTH production is from an ectopic site. If it is from the pituitary, then you are going to see decrease in both. Okay, in high dose. Okay, in high dose. Okay, let's move. Okay, and you can see the small cell lung cancer as well. Okay, Cushing syndrome. You can see the Cushing syndrome and the SIADH. Okay, paraendocrine neuroplastic disorders occurring small cell lung cancer and central location. Okay, in our case, the location is central. Okay. Okay, now read the question. "53-year-old woman comes to the physician for a routine checkup. She has no current complaints. Her past medical history is significant for osteoarthritis of the right knee. His mother suffered from hypertension and was diagnosed with breast cancer at an age 48. Okay. Her father died in a motor at age 56. Blood pressure is 140/85. So the only abnormal thing in this patient is that he is suffering right now is osteoarthritis, and the other thing is diabetes mellitus. The diabetes mellitus patients say most common cause of death in diabetes mellitus patient.
Heart.
MI, right?
And
MI is the most common cause of death in diabetes patient. Okay. And it is written here. Diabetes mellitus. In type 2, MI is the most common cause of death. Okay, MI is the most common cause of death in diabetes mellitus patient. Okay. So what would be the answer in this page? In this case,
C.
C would be the right answer. Okay.
Was decrease pain sensation.
Let's move on to the next one. Okay, so the patient has frequently involuntary loss of urine. Okay, for the past several months, he has been having difficulty starting and maintaining a urinary stream. Okay, he had 2 episodes of nocturnal enuresis and multiple daytimes of uncontrolled voiding without any sensation of full bladder. Without any sensation of full bladder. Okay. His other medical problems include CKD and gastroparesis as well. He does not use tobacco or alcohol, which are the additional findings which most likely to be present in this patient. Okay. Large prostate on rectal examination.
Maybe.
Okay, what type of a urinary incontinence it is?
Overflow incontinence.
Overflow.
Overflow incontinence.
Yes.
Okay. Give me a second. It is overflow incontinence. Why it is overflow incontinence? Why it is not stress incontinence or the other type of incontinence? What made you say that it is overflow incontinence and not the other type of incontinence?
Because
Due
due
to
to
pressure.
diabetes, he has less sensation of feeling micturition. That's why retroced underactivity.
Yes. Again, the patient does not feel any sensation of a full bladder. Okay. Overflow incontinence. Okay. In urgency incontinence, there is detrusor overactivity leading to leak with urge. Leak with urge. In this patient, there is no urge. Okay. So it is not urgency incontinence. Okay. Stress on incontinence, a leak with increased intra-abdominal pressure, positive bladder stress test. Okay. So when the patient sneezes or during lifting some heavy weight, so due to which the patient leaks the urine. Okay. But not in this case, the patient has uncontrolled voiding without any sensation of a full bladder. Okay. He has difficulty starting and maintaining a urinary stream. Okay. So the patient has overflow incontinence. Incomplete emptying can be due to two types: leak with overfilling, increase post-voidal volume, increase post-void residual on catheterization or ultrasound, and it can be diabetes. Okay, its cause can be diabetes. Okay, increase post-voidal volume. Now you have to tell me which one is consistent with this type with overflow incontinence. Which option? Does in a 42-year-old man you are going
E.
to see enlarged prostate? Is option A can be the right answer in a 42-year-old man?
No,
No.
no, never.
No. Okay. 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 Do you think the diagnosis is normal pressure hydrocephalus? Because in normal pressure hydrocephalus, you are going to see the hyperreflexia and the low cognitive score, the cognitive impairment.
No.
Do you think?
No.
Okay. Okay, now we are left with B and C. Do you think it is due to some kind of compression of the spinal cord that the
No.
patient is? It is
No.
not due to
No.
some type of
We
compression.
haven't.
Okay.
Yes.
Okay. Because if that it is due to some kind of compression, you are also going to see fecal incontinence.
Yes.
In
And all.
compression, the first signs are of fecal incontinence, then urinary incontinence. Okay. Increase post-void residual volume. Okay, overflow incontinence. Okay, it is written in the renal. Okay. Options. Okay. Okay. 34-year-old man, irregular in a 34-year-old a healthy woman, previously healthy woman, irregular menstruation, 4.5 kg weight gain, irregular menstruation weight gain. Okay. Muscle weakness where climbing stair in the shoulders or lift a climbing stair in the hip joints or lifting her child in the shoulder joint. The muscles in both of the that means proximal muscle weakness. Proximal muscle weakness is much more related to the increased steroid levels. Okay. Okay. Blood pressure is also elevated. Okay. Excessive fat accumulation where in the abdomen area and the supraclavicular area. Okay. Sun exposed hyperpigmentation. Okay, again hyperpigmentation. White stria over the abdomen. Okay, skin fragility is also increased. Coarse hair is present on the face, chest, and abdomen. Okay. Uh, is the ACTH is high or low in this patient?
High,
ACTH
high,
high. Why?
hyperpigmentation,
High.
How
hyperpigment
how do you come to into conclusion that ACTH is high? Because
pigmentation is
hyperpigmentation. We have just discussed that whenever ACTH is going to be high, the MSH is the MSH melanocyte stimulating hormone is also going to be high. Why? Because both of these compounds derived from a same precursor molecule, POMC. Okay, so because they both of them are derived from the same molecules, when the ACTH is going to high, MSH is going to high, and you are going to see hyperpigmentation. Okay, so option C, D, and E are eliminated. Now we are left with A and B. Is the symptoms skin fragility, increased muscle weakness, and there is accumulation of fat in the abdomen and the supraclavicular area? Are these are the symptoms of increased cortisol or less cortisol?
increase.
Increased
Increased
cortisol.
cortisol.
Option number B is also eliminated. Okay. So, okay, what will happen to the dihydroepiandrosterone levels?
It will
What?
also increase
Why they are also going to increase? Why?
because of stimulation of the adrenal gland, adrenal
By
cortex.
what? By what? By ACTH. Okay. So they
Yes,
By
are also be regulated by ACTH levels. Okay.
just aldosterone.
Dihydroepiandrosterone also regulated through ACTH.
Yes,
Okay, when ACTH is going to high, both the glomerulosa, both the fasciculata and the reticularis layer are going to produce increased amount of hormones. Okay, but aldosterone is not going to be increased. Okay, because it is not regulated by ACTH, it is regulated by angiotensin 2. Remember this difference.
yes,
Okay, if the main abnormality, the main pathological site is in the in the pituitary, or is it at any ectopic site, then aldosterone is not going to be high. It is only going to be high when the main pathological site is within the adrenal cortex. Okay, remember this difference. Okay, ACT and an increased ACTH also going to increase DHEA levels as well, dihypo and endosterone levels. Okay, now I will make another block. Okay, okay, just give me a minute. I will make another block and then we will start again. Okay, just give me 5 minutes. Okay. Okay, I will share my screen with you. You people, okay? This screen is. So after this, our patho and pathophysiology will be completed of the endocrinology. Okay, let's start. Which of the following laboratory test is most appropriate next step in the evaluation of this patient's symptom? Okay, see the options. Okay, now see all the abnormal findings in this patient. Increased fatigability, 4 point weight gain. Okay, the patient is much more fatigued now, weight gain. Okay, other than that, some but is not due to the fatigue. And the constipation, constipation, 3. Okay. Hair loss involving the lateral third of the eyebrows, delayed relaxation of the deep tendon reflexes. Okay. Diagnosis: delayed relaxation of deep tendon reflexes, hair loss involving the lateral third of the eyebrows, constipation, fatigue, increased fatigue, and the patient has weight gain.
Hypothyroidism.
Hypo or hyper?
Hypo.
Hypothyroidism. Okay, it is hypothyroidism. Okay, let's see. Hypothyroid effects. Okay. Okay. It is hypothyroidism. Okay. We are seeing weight gain in this patient. Brittle hairs. Brittle hairs, diffuse alopecia. The patient has constipation as well. The reflexes are decreased in this patient. Okay, so all of these symptoms, fatigue as well, all of the 5 symptoms can make sense through the hypothyroidism. Okay, now you have to tell me, for hypothyroidism, which one is going to be the right answer? Cortisol is not going to be dexamethasone, fasting, no, serum, E or F? Which one is going to be the right answer?
F.
F.
Why not E? If you are
F.
saying E, why not E? Why not E?
It takes longer.
Why not E is
Because
the right answer?
TSH is more sensitive for
Yes,
hypo.
TSH is most sensitive marker for primary hypothyroidism as compared to T4 and T3. The first, because TSH, a small change in thyroid hormone leads to large change in TSH level. Okay, you are going to a much more larger change in the TSH levels as compared to the thyroid hormones. Okay, that's why TSH is much more sensitive in primary hypothyroidism, and 90% of the cases of hypothyroidism are primary. Okay, they are not secondary hypothyroidism, they are primary hypothyroidism. Okay, 90% of the cases. Okay, and in 90% of the cases TSH is much more sensitive. Okay, the question as well, you can see increase TSH if primary. Okay, always start with TSH levels. Okay, so the right answer is going to be serum TSH level, not T3 or T4. Okay, T3 and T4 is also going to be less, but if you have to go with one answer, go with TSH. Okay, if TSH is not in the option, then go with T3 and T4. Okay, hypo TSH is much more sensitive. Yes. Okay. Which of the pathological processes is most likely responsible for these patient symptoms? See the patient. A 24-year-old woman comes to the postpartum follow-up 2 weeks after a term vaginal delivery. Okay. Baby is doing well, but she's going because she has not yet lactated. Not yet lactated. Okay. Which hormone is involved in lactation?
Prolactin.
Prolactin.
Okay, because she's not no longer lactating, that means prolactin is less. Okay. The patient knew she will lose weight, be tired after the baby, but excessive fatigue and significant weight loss. And other significant weight loss, nausea, loss of appetite, postural dizziness. She appears fatigued and has mild pallor. Hemoglobin is less. Cortisol is less or high?
Less.
Cortisol is also
Because of
less.
fatigue.
See if the TSH is less or high.
Yeah.
H
Less.
is less as well. TSH is
It's
also less.
less.
Okay, and free T4 is also less. Okay, so the cause of hypothyroidism, because T4 is less, is primary or secondary?
Secondary.
Secondary, because TSH is less. That means the cause is within the pituitary gland.
Pituitary.
Okay, so the patient is. So that means the patient is no longer producing ACTH, the patient is no longer producing prolactin, the patient is no longer producing TSH. All the
Sheehan
hormones,
syndrome.
all the hormones which are produced by the pituitary glands are no longer be produced. This state is called hypopituitarism. Okay.
Hypopituitary.
Okay. Now he is asking which one is the cause of hypopituitarism. Okay. So the patient was a postpartum patient. Okay, the patient was a postpartum patient. Okay. Okay, and we know that in postpartum patient, the only link in this question that is linked with the patient's scenario is that the patient is postpartum, and all of these symptoms develop after the delivery of the baby, and we know one case in which that after postpartum the patient develops a hypopituitarism. That case is
Postpartum.
Sheehan.
Sheehan syndrome. What happened in Sheehan syndrome? Ischemic infarct. Why? Because during the pregnancy, the pituitary sizes increases. Why pituitary size increases? Because of the increased demands of the body for the hormones. Okay, so that's why pituitary size increases. And when so if during the delivery the mother has excessive blood loss, that can lead to severe postpartum hemorrhage, can lead to ischemic infarct of the pituitary, because in pregnancy the pituitary has grown and now he has become much more susceptible to hypoperfusion, and if during the delivery there is increased blood loss, then there is going to be increased chances of ischemic infarct. Okay, failure to lactate, cold intolerance. Okay. Okay, so the patient has Sheehan syndrome, right? So what will be the answer in this case?
Ischemic necrosis.
Ischemic necrosis. A would be the right answer for what scenario? A would be the right answer. For what scenario? A would be the right answer. Pituitary apoplexy. Okay? Pituitary apoplexy. A would be the right answer for pituitary apoplexy. Okay? Non-malignant infiltration. Do you know a case of non-malignant infiltrative disease? that is also usually associated with the hypopituitarism? Sarcoidosis. Okay, sarcoidosis can also cause due to infiltrative lesion, can also cause a hypopituitarism. You will see one question regarding the sarcoidosis. Remember this, non-malignant infiltration. Ischemic necrosis, okay, infiltration. See the options. So see the question. Okay, 48-year-old woman, a chronic autoimmune thyroiditis. The patient has Hashimoto thyroiditis. Feel well, no palpitation, heat cold intolerance. The patient takes levothyroxine daily on an empty stomach. Good. Okay, blood pressure is 120/70, BMI is 27. The thyroid is normal to palpation. There is no peripheral edema, and the TSH is very suppressed. Okay. What are the TSH level? Less than 0.01 level. Okay. So he is asking what can be the side effects of levothyroxine here. And we can see that the serum TSH is very suppressed. Okay. Usually we keep the TSH levels between 0.5 to 5. Okay. When we are starting the thyroid replacement therapy. Okay, but in this patient it is less than 0.01. And now levothyroxine is basically thyroid hormones. Now you have to tell me which one is can be a side effect of increased thyroid hormone.
The atrial fibrillation.
Atrial fibrillation.
Agranulocytosis will be the side effect of what drug?
Anti-thyroid
Agranulocytosis
drugs. Anti-thyroid. Propylthiouracil.
and
Yes.
methimazole.
And also antipsychotic.
Valproic acid can also cause.
Yeah. Hepatotoxicity can be the side effect of what endocrine drug? Hepatotoxic. Which drugs are hepatotoxic and they are endocrine drugs?
PTO.
Sulfonylurea or
Propylthiouracil.
Okay.
Propyl.
Propylthiouracil and
Propylthiouracil.
methimazole. Okay.
Methimazole.
Okay. So the right answer in this case is atrial fibrillation because hyperthyroidism can lead to atrial fibrillation. Okay. Remember this. Which of the following is most likely to be seen on the thyroid biopsy of this patient? We have to first diagnose the patient, and after diagnosing the patient, we have to see which of these biopsy findings are consistent with our diagnosis. Okay. 16-year-old girl, excessive weight loss. Okay, excessive weight loss over the excessive weight loss, lost 4.5 kg, but thinks she still appears overweight. Okay, but thinks she still appears overweight. Okay, some kind of psychological issue here, and is worried about gaining weight. Okay, when she's losing the weight, okay, she does not use tobacco, alcohol, or illicit drug. Mother has hypo. Okay, so her mother has hypothyroidism. So most likely his mother is using some hyperthyroid drugs for her hypothyroidism, right? And okay, on examination, the patient appears anxious, thyroid is small, and without palpable nodules. Okay. The patient is anxious. There is fine tremor. Deep tendon reflexes are elevated. Skin is warm and moist. A TSH is decreased and elevated free thyroxine and an undetectable thyroglobulin levels. Okay. So what is the significance of thyroglobulin? How does thyroglobulins help us in this diagnosis? In this diagnosis?
It's exogenous. So
Yes. So remember when we are studying the insulin and C peptide levels? Same, the thyroglobulin is the C peptide of thyroxine hormone. Okay. So if the thyroglobulins are less, that means the thyroid hormone is taking, the patient is taking thyroid hormone from the outside. Okay. Her mother is hypothyroidism, so most likely this patient is stealing her mother medications. And in the question, it is clearly mentioned that even when the patient is losing weight, she still thinks that she is overweight. So most likely she is stealing her mother medications. That's why his thyroxine levels are high and thyroglobulin levels are low. Okay, because it is exogenous. Okay, it is not endogenous. And all the other symptoms, anxious, increased tremor, skin is warm, skin is moist, deep tendon reflexes are elevated, there is weight loss. All of these symptoms are the symptoms of a hyperthyroidism. Okay, and the cause of hyperthyroidism in this patient is
Exogenous.
exogenous
exogenous.
thyroid.
Okay, now we have to see which one of these is consistent with exogenous.
A.
Okay, option number D is consistent with what diagnosis? T cell hyperplasia. C cells produces which hormone?
Calcitonin.
Calcitonin. And okay, so D is consistent with medullary thyroid cancer, right? Okay. Tall columnar follicular epithelium with scalloped margins of the colloid. Diagnosis. Option number E, diagnosis. Graves' disease. Very good. Graves' disease. Multinucleated giant cells and inflammatory disruption of the follicles. Diagnosis. Granulomatous inflammation of the
D.
thyroid.
Convan.
D. Corrosion. Very good. Extensive lymphocyte infiltrate with germinal center.
Hashimoto.
Hashimoto.
Hashimoto or postpartum thyroiditis. So the right answer is going to be A, diffuse atrophy of the thyroid follicles. Because when you are going to take outside thyroxine, the endogenous cells are going to atrophy because they are no longer being needed. Okay. Okay. So on to the next one. Okay, 6-year-old boy brought to the emergency department, traumatic fall, large laceration of original end that is irrigated and closed with sutures. While he is receiving care, draws milky plasma. What plasma? Milky plasma. Okay. Creamy appearing supernatant. Lipoprotein lipase activity made after is substantially lower. So is there any diagnosis which is coming inside your head in which there is milky plasma, creamy appearing supernatant, and decreased lipoprotein lipase activity?
Familial hypocholesterolemia.
Yes, it is familial hyperlipidemias
Hyperlipidemia. Yes.
type 2.
Right.
Okay, so it is not written in the endocrinology, it is written in the biochemistry section on the last page. Okay, so don't worry if you do not get this question. Okay, because it is not mentioned in the endo, it is mentioned in the
Biochemistry.
yes. Okay, So, okay, it is type 1 creamy layer in the supernatant, which is present in our patient. Okay. And eruptive hepatosplenomegaly, and the lipoprotein lipase activity is less. This is happen in type 1 hypercholero. Okay. So what are the symptoms are also present? Eruptive and purpuritic xanthomas, not tendon xanthomas. Tendon xanthomas are present in type 2. Okay, tendon xanthomas are present type 2, not here. Okay, tubereruptive and palmar here. Okay, here eruptive and pruritic xanthomas, pancreatitis, and hepatosplenomegaly. Okay, not xanthelismas as well. Okay, remember this. Okay, what would be the answer here?
A.
A.
Acute pancreatitis. Okay, pancreatitis, creamy layer. Creamy layer in supernatant is very pathognomic for type 1. Okay, and lipoprotein lipase is also less in type 1. Okay, that through these options we came to conclusion that it is type 1, and we know in type 1 pancreatitis is the most likely. Okay, not tendons and thomas, not xanthelisma, there is no intellectual disability, not myocardial infarction. Okay, this type. Okay, examination of this patient adrenal glands is most likely to reveal which of the following findings. See the options. No. 45-year-old woman calls 911 due to chest pain and dyspnea. The emergency medical find the patient with no pulse, unresponsive with no pulse. Okay, and she does not revive despite extensive CPR. Okay, she had a prolonged history of SLE treated with multiple medications. Prolonged history of SLE treated with multiple. Do you know what type of medication we usually use for SLE?
Corticosteroids.
Yes,
Right.
corticosteroids. And she has a prolonged history of SLE. Okay, with multiple medication, and was recently there is progressive muscle weakness as well. And muscle weakness is seen in what? Increased steroids. At what level? Proximal muscle weakness. Okay. Shows an elevated blood pressure, facial pulpothera, frontal obesity, skin ecchymosis, hyperglycemia. Okay, left hip replacement for osteonecrosis of the femoral head 1 year ago, occluding thrombus in the left main coronary artery, leading to sudden cardiac death. Okay, so does the patient has high cortisol or low cortisol?
High cortisol level.
High
High
cortisol. Okay,
due
now
to
we have to find
moodiness.
out what is the cause of that high cortisol level. The patient is seeing all the symptoms of high cortisol,
Yes.
like skin fragility, truncal obesity, facial plethora, hyperglycemia. All of these are the symptoms of high cortisol. Now we have to find out what is the cause of high cortisol in this patient. Okay, the only thing which the patient in this scenario which is given to us, that the patient has SLE and for which he is using medication for a prolonged time, for a prolonged period, and we know that in SLE we use high dose steroids, right? Okay, so which one do you think the main pathology site is going to be within the adrenal glands, or do you think it is going to be iatrogenic, the cause?
Adrenal.
Iatrogenic.
Adrenal.
You think it is adrenal. The cause of high cortisol is adrenal.
Exogenous, most likely due
No,
to
it's
the
exogenous.
patient's steroid.
Yeah, the cause here is the exogenous. Okay, because the patient is taking large amount of steroid, that's why he is going to be producing large amounts of it. That's why his cortisol levels are elevated. Okay. Okay. Hypercortisolism. Okay, and it is the most common cause of Cushing syndrome, most common. Okay, exogenous glucocorticoids decrease the ACTH, and due to which we are going to see bilateral adrenal atrophy. Okay, we are going to see bilateral adrenal atrophy, and it is the most common cause of Cushing syndrome. Okay, not adrenal adenoma, hyperplasia, or carcinoma, not pituitary adenoma. Exogenous steroids is the most common cause of Cushing syndrome. Okay, and what will happen to the adrenal gland in this? What will happen to the adrenal glands in
Atrophy.
exogenous? They
Atrophy.
are going to atrophy. Okay, okay, see this. A glucocorticoids side effects: Cushing syndrome, osteoporosis, hyperglycemia, adrenocortical atrophy, avascular necrosis of the femoral head. Is our patient has osteonecrosis of the femoral head?
She has everything.
Yes.
Yeah, the patient has an hip replacement for osteonecrosis of the femoral head. Okay, that's osteonecrosis due to the exogenous steroids. Okay, due to the glucocorticoids. Okay, what will be the answer here?
B.
B.
Maybe atrophy.
Okay, adrenal cortical atrophy. Okay, due to because it is iatrogenic. Okay, exogenous. Okay, okay, we have to make different hormones. Okay, okay, here's the question. Okay, 27-year-old man infertility evaluation. Okay, trying to conceive for the last 16 months. Previous evaluation of his wife showed no abnormality. That means his wife is normal. The problem is within the man. Okay. Height is 6.2. Okay. Weight is okay. Heart and lung sounds are normal. Bilateral gynecomastia. Bilateral gynecomastia. Small firm testes. Okay. The lower extremities are abnormally long. Okay. Okay, small firm testes mean that the cells within the testes are atrophied, right? Right? A- And
Yes.
that means that the testosterone production is
Low.
Decreased.
low.
Decreased.
Okay, so
FSH, LH, and high, and sperm
okay,
count is
so
absent.
they are going to be low. Okay, and sperm count is also going to be
Decrease.
No.
is it either going to be decreased or either is going to absent. Okay, let's first try to diagnose the patient. Okay, abnormally long patient, bilateral gynecomastia, and small firm testes, and infertility. Does all of these things ring any bell? Any infertility cause in which you are going to see bilateral gynecomastia and a and small and firm testes
XXY.
Yes.
in
Yes.
the
Marfan. Marfan.
Leinfeld.
Marfan
Leinfeld.
Klinefelter syndrome. Yeah.
Klinefelter.
FSH,
Marfan
LH
syndrome
is
does not have
high.
infertility issue.
Testosterone is low.
Yes,
And
small firm testes, and the cause here is Klinefelter.
Klinefelter.
Okay, all of these findings are consistent with the Klinefelter syndrome. It is not Marfan, okay? Klinefelter syndrome. Okay. Small firm testes, which is present in our patient. Infertility, also present. Azoospermia. Azoospermia. Azo means absent sperms,
Absolutely.
not decreased sperms. Absent sperms. Tall stature with delayed long bone length. Our patient has 6.2, he is a 6.2 inch height and 6 foot 2 inch height and has extremities abnormally long. Bilateral gynecomastia. Okay. All of these findings are present in our patient. So the diagnosis in our patient is Klinefelter syndrome. Okay. Okay, what happened in Klinefelter? There's dysgenesis of seminiferous tubules, decrease in inhibin B, increase FSH, abnormal Leydig cell formation, and decreased testosterone and LH and increased LH. Okay, so sperm count will be absent, azospermia, not hypospermia, azo. Okay, FSH and LH are going to be increased. Okay, you can see FSH is increased, LH is increased.
Doctor, can you please explain this again? I didn't understand the LH effects and testes.
LH and because in the because the main pathological sites here is in the testes. Okay, there is dysgenesis of the seminucleus tubules and the Leydig cells. Cells are also not normal, but your hypothalamus and pituitary are are normal. Okay, when there is less testosterone, how does pituitary is going to respond to that? By increasing a LH and FSH. Okay,
Yes, enough.
because pituitary is normal, there's no issue with the pituitary. The issue is with the testes. Okay, that's why the testosterone is not producing. Okay, that's why the sperm count is 0. Okay, so because the pituitary is normal, low testosterone count, a normal response to low testosterone count is increase LH and FSH levels. Okay, inhibin is less, that's why FSH is also be high. Okay,
Okay.
this Klinefelter bilateral gynecomastia. Okay, okay. Okay, now read the question. 34-year-old woman experiences nausea, abdominal pain, dizziness after undergoing a surgery for a fracture. Okay, okay, okay. Sometimes these are also important. Like in the previous one question, we said that after the postpartum, the patient develops symptoms. And in this case, we can see that after the surgery, the patient develops these symptoms. Okay. Okay. Now continue. Nausea, abdominal pain, and dizziness. 1 year ago, she was diagnosed with SLE with significant renal involvement. And she has since been on chronic glucocorticoid therapy with prednisone. Okay, so what will happen to the adrenal glands? They are going to be atrophied, right, in this patient? Okay. The patient was maintained on her usual dose of prednisone throughout the perioperative period. She was on usual dose, not on increased dose, usual dose. Okay. Compared to the normal physiological response to the surgery, the patient most likely has which of the following patterns of the hypothalamic pituitary adrenal axis activity. Okay. Okay. So what because we in iatrogenic when the patient is taking exogenous steroids, what will happen to the cortisol levels of
They
the,
decrease.
yes, they are going to be decreased. What will happen to the ACTH levels?
Decrease.
What will happen to the CRH levels?
Also decrease.
Decrease.
All of them are going to be decreased because now the patient is taking exogenous steroids, and due to that the patient is thinking, the body is thinking that the body has already high cortisol, and that's why he's going to decrease the production of all of these hormones. Okay. Okay. Okay, so in this case, the patient develops an acute adrenal insufficiency because when the patient was on a usual dose, and if any stress appears, we need to increase the steroid dose. Okay, but in this case, we did not increase the steroid dose. That's why the patient goes into an acute adrenal insufficiency. Okay, because the patient has a surgery, that means there is an increased stress on the body. Okay, and when there is increased stress, you should increase the steroid dose, but the doctor does not increase the steroid dose. The patient was on the usual dose. Okay, that's why the patient goes into an adrenal insufficiency. Okay, because the body's own adrenal glands are already atrophied, right? Because the patient was on a chronic glucocorticoid therapy, because now the patient cannot respond to increased stress by increasing the formation of steroids. Okay, because he is taking from the outside, he is now dependent on the outside steroid. Which of the following is the most likely underlying cause of this patient joint symptoms? Okay. Okay. Let's first try to make the diagnosis here, see all the abnormal findings here. 45-year-old man, 6-month history of headache, sweating, and pain in lower back, knees, and small joint. Okay. Headache, sweating, pain. Okay. The pain increases with physical activity. Okay. Unable to move, remove his wedding finger due to swollen fingers. Okay. Excessive urination and loss of libido as well. Prominent jaw and enlarged supraorbital ridges. Enlarged supraorbital. Okay, so now, okay. Hands are notably broad with thickened fingers. Multiple skin tags. Low serum testosterone levels as well. Okay, so what is the most likely happening in this patient?
Acromegaly, pituitary adeno.
Okay. These are all the symptoms of acromegaly. Okay. Supraorbital ridges are elevated. Okay. Supraorbital ridges, and let me open acromegaly. Okay. Excess growth hormone. Frontal bossing. Our patient has frontal bossing. Our patient has coarsening of facial features. Okay. The patient has enlarged jaw. Okay. Our patient has glucose levels. The patient has excessive urination, right? That is due to the glucose intolerance. Okay. Hypertrophic arthropathy. What arthropathy? Hypertrophic. Okay. Diaphoresis. The patient has excessive sweating. Okay. Okay. Type of arthropathy we are going to see in this patient, hypertrophic. Remember this word. Okay. Okay. Now comes back to the question. Okay. So what will be the answer here? The diagnosis is acromegaly.
Hypertrophy of articular cartilage.
Because the type of arthropathy we see in acromegaly cases is hypertrophic arthropathy. Okay. It is not gout, so B is not the answer. It is not hemochromatosis, no, A is not the answer. Okay, it is not sarcoidosis, then C is not the answer. It is not rheumatoid arthritis, E is not the answer. It is hypertrophic arthropathism. Skin tags, large facial, large bones, peripheral arthropathy. Let's move on to the next one. This hormone is most likely secreted in the system. Which of the following site? Okay, we first have to find out the hormones. Okay, so he must have given some type of clue regarding that hormone. Okay. Okay. The patient has headache and mild confusion. Has a seizure disorder taking carbamazepine. Okay. Physical examination shows no abnormalities. Decreased sodium concentration. Okay, okay. And the hormone is co-secreted with neurophyzins. Okay. Carbamazepine, headache, mild confusion, low sodium, and neurophysin. What hormone comes inside your head? Carbamazepine affects the secretion of what hormone?
ADH hormone.
ADH.
Yes, carbamazepine affects what hormone? ADH. Okay. You can see carbamazepine, ADH. Low sodium can also be explained by the ADH, right? And for neurophysins, okay, posterior pituitary hormones are transported to posterior pituitary by neurophysins. Vasopressin and the oxytocin are both transported by what? Neurophysin. And in the question, he has mentioned that they are co-secreted with what? With neurophysins. Okay. So we know that the hormone involved is ADH, right? That's why he has low sodium. That can also explain the carbamazepine use. That can also explain the headache and mild confusion because of the cerebral edema due to the low sodium, and also explain the neurophysin. Okay, posterior pituitary is produced at what site? Is produced at what site?
Hypothalamus.
Is produced at the hypothalamus, right? And it is secreted where?
In neuropathy.
In the posterior lobe. Remember this. Sometimes they ask a trick question like ADH and oxytocin are produced in the supraoptic and the paraventricular nucleus of the hypothalamus. They are produced there. They are not produced in the posterior pituitary. They are secreted from the posterior pituitary. Okay. In the question, because he is asking secreted, so we are going to go with the posterior lobe. Okay. Let's move on to the next one. Which of the following? Okay, see the options. Okay, now try to make the diagnosis. 34-year-old woman. Okay. Okay, let's first try to make the diagnosis here. 34-year-old woman, 1 week history of mood swings, difficulty concentration, and hand tremors. Okay, mood swing, concentration, hand tremors. Okay, also has pain at the front of the neck. Pain. Okay, pain at the front of the neck that radiates to her ears and is worse when swallowing. Flu-like attributed her symptoms to a flu-like illness that she had few weeks earlier. Okay, blood pressure is high, pulse is high, thyroid gland is tender. After initial laboratory testing, thyroid scan is performed and reveals a diffusely decreased radioiodine uptake. Okay, diffusely decreased radioiodine uptake. Okay, ESR is also elevated. Okay, so which disease or pathology is can explain all of these features? Flu-like illness. The patient has a flu-like illness before the start of the disease. Thyroid is tender. Okay, and the symptoms are of hyperthyroidism or hypo.
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 The symptoms are of
Hypo.
Hypo.
Yes, hypo then.
the patient has
Low mood.
hand tremor. The patient has hand tremors,
Hyper, not
difficulty
hypo.
Hyper. Hyper.
that are
Hyper.
that are hyperthyroidism symptoms. Okay, that are hyperthyroidism symptoms. Okay, okay, okay. Let's
Also not play game here.
okay. The diagnosis is D covariant thyroiditis.
Go
Okay,
from.
okay. In the early stage, you are going to see hyperthyroidism symptoms. Like whenever there is a start of the inflammation and the cells get destroyed, the preformed thyroxine hormone, which is inside the cells, is going to get released into the bloodstream. And then you are going to see the symptoms of the hyperthyroidisms, right? Because the cells are destroyed and in the inflammation process, and the preformed thyroxine hormone, which is inside the cell, is released into the bloodstream. At the early stage, hyperthyroidism, and the later stage, you are going to see hypo. Okay, hyper, euthyroid, and then hypothyroidism. Okay, okay, often preceded by a viral illness. Our patient has a flu-like illness before the appearance of these symptoms, right? Right? Our patient ESR is elevated, right? Our patient has jaw pain. Our patient has a tender thyroid, right? Okay, on histology, what type of we are going to see in this patient? Granulomatous inflammation. Okay, okay, okay. Thyroid scan, they shows decreased thyroid radioiodine uptake. Why?
It is itis condition.
Inflammation.
Yes, because it is inflammation. The cells are destroyed. The only reason we are seeing the hyperthyroid symptoms is because of the preformed thyroid, which is in the cells which are destroyed, and now that preformed thyroxine hormone is released in the bloodstream. But the cells are no longer present there to use to uptake the radioiodine. Okay, that's why you are seeing on the lab finding, you are going to see that the thyroid gland is responding like a hypothyroid state. Okay, because it is inflammation here. Okay, so branching papillary structures with interspersed calcified bodies. Diagnosis: option A, papillary thyroid cancer. Calcified bodies are psammoma bodies. Okay, extensive stromal fibrosis extending beyond the thyroid capsule.
Riddles.
Yes. Okay. Option number follicular hyperplasia with tall cells forming intrafollicular papillary projections? Option
Graves.
number C.
Graves
It is
disease.
Graves. It is Graves. Follicular with tall cells. We have seen this option for the third time now. Follicular hyperplasia, tall cells, intrafollicular, papillary. Why intrafollicular papillary? That's mean the colloid is less. That's why we are going to see invagination within the colloid. Okay. Okay. Which one is going to be the right answer? D or E?
And
D.
cancel.
D is the right answer because in granuloma, yes, because we have seen that it is granulomatous inflammation. Okay, and when there is granulomas are involved, what type of cells we see in granulomas? Multinucleated giant cells,
Multinucleated giant
epithelioid
cells.
cells, which we also see in sarcoidosis, in TB as well. Okay, and option number E is consistent with what diagnosis? Option number E is consistent with what diagnosis? Hashimoto. Okay. Germinal centers are going to be seen in Hashimoto. Okay. Okay. 45-year-old man, sudden onset headache with a brief loss of consciousness while working in his yard. CT scan of the brain reveals basal stem from a ruptured intracranial aneurysm. Is hospitalized, endovascular coiling of the aneurysm is performed. His symptoms gradually improve, but the patient develops worsening hyponatremia. But the patient develops worsening hyponatremia. After brain injury, the patient develops worsening hyponatremia. Which of the following is the most likely cause of patient hyponatremia?
SIADH.
Yeah.
SI? Yes. SIADH is the cause here.
Euvolemic
Yes.
natriemia.
Yes. Euvolemic hyponatremia. Right? Euvolemic hyponatremia. And we know what are the causes of the SIADH?
Brain trauma.
Brain trauma,
Severe
brain
EMS,
Trauma,
pneumonia.
CNS disorders,
subarachnoid hemorrhage.
exogenous hormone, lung disease, drugs. Okay. In this case, it is brain injury. Okay. Defective central thrust regulation, no. Impaired, no. No. Increase. Is LDH. Okay. 1.5 centimeter, right? Adrenal mass. Okay. We have to first diagnose and then have to tell the all the findings here. Generalized weakness and paresthesias. Low plasma renin activity. Which of the findings will most likely be seen in this patient? Okay, the renin is low. There is generalized weakness and paresthesias. Okay, that a blood pressure was elevated at a workplace. Okay, higher blood pressure. No pedal edema. distal symmetric distal pulses, low plasma renin. Plasma renin is low, and there is a right 1.5 centimeter right adrenal mass. So the main pathological site is adrenal. Renin controls which adrenal hormone?
Aldosterone.
Aldosterone.
Okay,
Aldosterone.
aldosterone. And we know the main pathological site is within the
Adrenal.
adrenal gland
Adrenal.
because there is a mass here in
Cortex.
the adrenal gland. That means the hyperaldosterone in this patient, is it primary or is it secondary? It is primary.
Primary.
Okay,
Primary.
that's why you are seeing less. That's why you are seeing less renin here. Okay, because the main pathological site is adrenal. High aldosterone, low renin, and the high aldosterone can also explain the weakness and paresthesia. Okay, what will happen to the potassium levels in high aldosterone?
Low.
Hypokalemia. Is that
Low.
right?
Hypokalemia.
Hypokalemia.
Alkalosis. Reduce.
Potassium is going to be low.
Low.
What will happen to the bicarb levels?
It's going to be high.
Increase.
Yeah.
Bicarb
Alkalosis.
is also going to be high. So we are left with two options, A and B. Okay. So what will happen to the sodium level?
High.
Okay. So
Be
sodium is
normal.
can be,
Normal.
it either can be
Normal.
normal or it can be high. So we are
High.
know that option A is not the right answer, right? Option A cannot be the right answer. We are left with option B. Okay, but you have to tell me why it is normal, not high. Why it is normal, not high?
Compensatory ANP, BNP.
Yes, because
Yes.
because of the aldosterone escape
Aldosterone
mechanism.
escape.
Escape. I just never escape.
Yes, because of the aldosterone escape mechanism. Okay, because aldosterone is a mineralocorticoid. It is going to conserve the minerals. Okay, it is going to increase the sodium levels. Okay, so the in the options, the answer can be either high sodium or normal sodium. Low sodium can never be the answer. Okay, in the case of high aldosterone. Okay, when there is high aldosterone and your body is starting to conserve the sodiums, with the other ADH and the ANP and the BNP levels all are working normally. Okay, so when there is high sodium and high water retention, ANP and BNP levels are going to increase and they are going to decrease the sodium levels, and it's going to come back from high to normal. Okay, due to the aldosterone escape mechanism. Okay, primary hyperaldosteronism does not causes edema. Our patient does not have edema due to the aldosterone escape mechanism. Okay, we are going to see decreased or normal potassium and metabolic alkalosis. Okay, now see the primary hyperaldosteronism. Aldosterone is going to be high and renin is going to be low. Okay. Okay.
Doctor, can you explain the aldosterone escape mechanism?
Okay. So in aldosterone escape mechanism, what is the function of aldosterone? The function of the aldosterone is to conserve
Steroid.
the sodium and to excrete the potassium. Okay, in primary hyperaldosteronism, primary hyperaldosteronism, the body initially retains the sodium and water, okay, leading to the increased blood pressure and potentially edema. However, after a short period, the kidneys escape the sodium retaining effects of the aldosterone, and urinary sodium excretion is going to increase, preventing the further edema formation. Okay, how this is going to be occur? By increasing the ANP levels, by increasing the BNP levels. Okay, because they are going to excrete they are going to increase the diuresis. They are going to, because when there is increased sodium retention, increased water retention, there is going to be much higher blood pressure. Okay, and that higher blood pressure is going to detected by those cells, and they are going to release the ANP BNP levels, increase the ANP BNP hormone, and that ANP and BNP are going to excrete the excessive sodium and water back into the urine, and in this way we are going to see we are going to see a decrease in the blood pressure. There will be no edema, and there will be normal sodium. Okay, this is called aldosterone escape mechanism. Because other than aldosterone, all our other body parts are working normally. Okay, so they are going to try to compensate for that. Okay, and to bring that the whole of our body function to a normal value. Okay, this is called aldosterone escape mechanism. This is the same how the euvolemic hyponatremia occurs in SIADH. Okay, this is the same like the euvolemic hyponatremia. Okay, let's move on to the next one. See, limits the aldosterone escape, the inner blood flow increases, GFR increases, ANP is going to increase, which is going to increase the sodium excretion. Okay. Okay. Which of the following condition is most likely cause of these findings shown in this image? Okay. Okay. See the photo. Now comes to the question. Okay. Is brought to the emergency department by following a motor vehicle collision. He was unrestrained persons in the several days after his fluid volume and serum osmolarity are depicted in the image below. Solid lines are the normal line. A solid lines are the normal line. Dotted line are the patient. Dotted line is the patient. The y-axis shows the osmolarity, and the x-axis shows the compartment fluid volumes. Okay. Dotted line in the patient. The osmolarity in the extracellular fluid is increased or decreased?
Increased.
Osmolarity.
Increased in both.
In both compartments, it is increased.
Again, see, dotted line is patient. Okay. And see the osmolarity in the extracellular fluid. Solid line is the normal. Okay, osmolarity is increased. Yes, osmolarity is increased.
Yeah.
Yes, osmolarity is increased. The fluid volume is decreased in both of these. Okay, so osmolarity is increased. Okay, in primary adrenal insufficiency, Okay, let's first start with syndrome of inappropriate ADH secretion. In SIADH, are we going to see hyponatremia or hypernatremia? Hyponatremia. That means osmolarity is going to be low, right?
Low.
Yes.
But in our case, it is high, right?
High.
A is not the answer. Okay. Now, in acute gastrointestinal hemorrhage, do you think in hemorrhage are we going to see any change in the osmolarity?
No, there will be same.
Okay.
No,
Yeah,
volumes
they're going to, the fluid volumes are going to be less,
low.
but the
Yeah,
osmolarity is going to be remain the same.
same.
Later on may decrease.
Okay. So we are left with B, C, and D. Okay. What will happen in the primary adrenal insufficiency? What will happen in the primary adrenal insufficiency?
Yeah, we
Decreases
Uh,
of
yes, in the osmolarity is going to decrease. Why? Because aldosterone works by conserving the minerals. If you do not have a mineralocorticoids, you are going to lose the minerals. So the sodium is going to be less. You are going to see hyponatremia. But in the question, you can clearly see that the dotted blue line is above the with the solid line. Okay, on the y-axis. Okay, now we are left with B and C. Okay, now you have to tell me what will happen to the osmolarity in the diabetes insipidus. Osmolarity in the diabetes insipidus.
Low
It
Would be
because of
increase.
Increase.
excretion, increase
yes,
excretion.
because
High.
you are
High
going to
increase
yes, yeah, because you are losing large amount of free water from the body because ADH is no longer present there to conserve the water and you are losing large amount of water. So what you are going to see increased osmolarity, which is consistent with our patient. And what will happen to the fluid volumes? Are they going to
It
decrease?
will also decrease.
Yes, because
Decrease.
they are also going to decrease. Okay,
Decrease.
because you are losing the free water in diabetes insipidus. Okay, so the right answer is going to be
DI.
diabetes
B.
insipidus. Okay,
Insipidus. The organic.
it is diabetes insipidus. In diabetes insipidus, serum osmolality is going to be increase always. Okay, increase. Okay, whether it is central or whether it is nephrogenic, the osmolarity is always going to be increased. Okay, and because we are seeing large amount of water loss in the urine, the fluid volumes are going to be decreased. Okay, which is much more consistent with this graph. Okay, which of the following describe the primary mechanism by which agent reduces the hirsutism? Okay, first try to diagnose the patient, then we will. "25-year-old woman, facial hair growth worsened over the past several years. The patient is very concerned. It makes her feel self-conscious in public. Tried several cosmetic measures, including laser removal and waxing, but the results have been unsatisfactory. Past medical history is insignificant, takes no medication. Last menstrual period was 6 weeks ago, and she regularly has long cycles and feels otherwise well. She's sexually active with her boyfriend. Okay. Uh, Irregular menstrual cycles as well. Okay. And uses and infertility as well, and obesity as well, and hirsutism as well. She's initiated on combined OCPs. Okay. What is the diagnosis here?
PCOS.
polycystic ovarian disease.
Polycystic disease.
Yes, the diagnosis is polycystic ovarian syndrome. Okay. Okay, polycystic, the hirsutism develop in this patient. Why? What is the cause of hirsutism here?
Increased androgens level.
Increased
Electrolytes.
androgens level.
And androgens.
Disorders. PC, increased LH over FSH, increased androgens from theca internal cells. Okay, so OCPs prevent endometriosis due to non-positive. Okay, okay. A with option number D, inhibition of FAL5 alpha reductase is the function of which drug?
Tried for treatments for BBH.
It is the function of
Aromatase
finasteride. It is the function of finasteride. Androgen receptor antagonist. Androgen receptor. Very good. Spironolactone. Okay. Okay. OCPs do increase the insulin sensitivity, but that is not the way how they're going to do reduce the hirsutism. Okay, then the main drug which is used for increasing the insulin sensitivity is metformin, and we
Metformin.
are talking about OCPs here. Okay, the patient is not started on metformin. Okay, blockade of ornithine decarboxylase, no, that is not happen in here. So the right answer is, and the diagnosis is PCOS. Okay. See the option. Follow up appointment 4 months after giving birth a healthy boy. Okay. Okay. The patient, for the past 3 weeks, the patient has progressive fatigue with loss of interest, irritability, poor concentration. In the 2 weeks prior to the onset of fatigue, the patient has excessive sweating and palpitation. Okay. The thyroid gland is firm, diffusely enlarged, non-tender. Non-tender means this is not decovariant thyroiditis.
Not decadent.
Okay. Right now, the patient has elevated serum TSH and low free T4. Okay. Right now, the patient's symptoms are of hypothyroidism, and and a and a few time before the patient has hyperthyroidism. Okay. Okay. And the patient and the symptoms develop 4 months after giving birth to a healthy boy. Okay, so they are clearly linked to the postpartum. Okay, so what is the diagnosis here? The diagnosis is postpartum
thyroid.
thyroiditis. Okay, because the symptoms clearly developed after the uh, postpartum state. In the postpartum state, and the patient first develops hyperthyroidism and then hypothyroidism symptoms, which are usually seen in thyroiditis. Okay. Okay. Postpartum thyroiditis is the first here. And let me see. Okay. Postpartum mild self-limiting variant. It is a variant of Hashimoto thyroiditis. Okay. So the main, it is a variant of Hashimoto. So the same histology which you are going to see in Hashimoto, you are going to see here. Okay. After delivery, first within the 3 months of birth, hyper, then hypo. Okay. Okay. And what is the histology of Hashimoto? Lymphoid aggregates with germinal centers. Okay. Okay. Option number A will be the diagnosis for what pathology?
Renal thyroiditis.
Okay. Option number A is going to be for
TQI.
renal
Renal
thyroiditis.
D.
Option number B would be the would be the answer for what? Yeah, that can be answer for sarcoidosis or tuberculosis. Okay, any granulomatous disease of the. Okay. Option number C.
Dequarian.
Look, very good. Okay. So what will be the right answer here? D or E? Which one is going to be the right? D, because the main pathology is
In thyroid,
thyroid.
not pituitary.
Yes. Postpartum thyroiditis. Okay, let's move on to the next one. Which of the following most likely mechanism for this patient amenorrhea? Uh, Okay, what is going to be the answer here? 16-year-old girl, okay. Pre-participatory school sports examination, plays on her high school soccer team, and also frequently competes in local beauty pageants, okay. The patient follows strict dietary limitations and exercise strenuously 2 hours a strict dietary limitations. Okay. And exercise strenuously. Okay. Onset of menstrual was at age 13, but her last menstrual period was 8 months ago. Okay. She otherwise feel well. Height 5, BMI 16.6. BMI is very less. Pale and thin girl. Fine here. Urine pregnancy test is negative. Okay, urine pregnancy test is negative. Okay. Do you think the symptoms are due to hyperthyroidism?
No.
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 Okay. Do you think hyperprolactinoma is the cause?
No.
Why do you think hyperprolactinoma is not the cause? In hyperprolactinoma, there is amenorrhea.
Galacturia. No
Yeah,
galacturia.
the patient has no galacturia, and how are you going to explain the low body weight and calorie restriction and strenuous exercise regime? Okay,
And also
very
no
good.
visual disturbance.
Okay. Okay, now we are left with C, D, and E. Okay. Okay, I have to see. Okay, so the diagnosis which is consistent with this, which can explain all the features in this main is functional hypothalamic amenorrhea, also called exercise-induced amenorrhea. Severe calorie restriction. Our patient has calorie restriction? Yes. Increased energy expenditure. Our patient has increased strenuous exercise regimen, right? So
Yes.
energy expenditure is going to be high and stress. Okay. What will happen here? Functional disruption of pulsatile GnRH secretion, decrease LH, FS, and estrogen. Pathogenesis includes decreased leptin and increased cortisol. Okay, this is called female athlete triad. Calorie availability is less and exercise excessive. Bone mineral density is also going to be less. Menstrual dysfunction is going to be less. Okay, we are going to see a disruption where in the pulsatile GnRH secretion. Okay, GnRH is secreted from where? From hypothalamus, pituitary, or ovaries?
Hypothalamus.
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 Okay, so what will be the answer here?
C.
Hypothalamic secretion.
Which of the following is most likely explanation for this patient abnormal? Abnormal finding. Okay. Please. Okay. 25-year-old man comes to the office for evaluation of a facial acne. First symptom, facial acne. Patient age is very young. Okay. Does not use tobacco, alcohol. The patient work as a personal trainer. Personal trainer. Okay. Family history, significant diabetes, mellitus, leukemia. Blood pressure is little bit elevated, 134. Mild facial acne. Liver span is 8 centimeter. Skin is not palpable. Testes are small and testicular volume is decreased. Testes are small, testicular volume is decreased. Hematocrit is 60%. Hematocrit is 60%. Okay. Which of the following is the most likely explanation for this patient abnormal finding? Which one is going to be the answer here?
E.
E. Steroid drug abuse. Okay, if you see, he's a young man who is a personal trainer. There's facial acne there. The testes are soft and testicular volume is decreased. You cannot explain that through renal artery stenosis. Okay, you cannot explain the small size of testes through a high oxygen affinity hemoglobin. Intensive exercise schedule does not decrease the testicular volume. Myeloproliferative disorder cannot explain the testing findings, the acne. Okay, it can explain the increased hematocrit. Okay, volume depletion can explain the high hematocrit, but that cannot explain the decreased testicular volume. Okay, only androgen abuse can explain these findings. Okay. Okay. 29-year-old woman, unintentional weight loss, fatigue, and sweating. Hyper or hypo?
Hyper.
Hyper.
Hyper. No neck pain. That means decovariant thyroiditis
No
is
discriminate.
eliminated. Okay, 2 months ago she delivered a healthy baby. Okay, it is linked to delivery of a baby. Okay. Blood pressure 140/70. Okay, pulse 110. Respiration Neck examination, mild diffuse enlargement of thyroid gland. There is goiter there. Okay. Low serum TSH, elevated serum thyroxine, and elevated serum triiodothyronine. Thyroid receptor antibodies are negative. Okay. What is the diagnosis here? Hyperthyroid state within the first 3 months of delivering a baby.
Postpartum.
Diagnosis:
Postpartum
Yep.
Postpartum thyroiditis.
postpartum thyroiditis. Right? Okay. C will not be the right answer, right? Tumor production of beta hydroxy, no. Exogenous, no. Okay. Which one is going to be the right answer?
D.
D.
B will be the right answer for what?
D. D.
For decurrence.
Decovariant
Shimura.
thyroiditis. B will be the right answer for decovariant thyroiditis. Okay.
Yes.
Okay. Let's see this question. Okay, 14-year-old boy brought to the physician by his mother. She is concerned because although she is tall, her son look much younger than his parents. Okay, her son looks much younger. Okay, no signs of masculinity. Poorly developed secondary sexual characteristic. Poorly developed secondary sexual characteristic. Unable to distinguish smell. Okay. Unable to distinguish smell. Okay. Which of the following pathway is most likely to be present here? Okay. Do you know a cause in which you are going to see hypogonadism and decreased ability to distinguish smell?
Kalman syndrome.
Yeah. It is in Coleman syndrome. Okay. Open up. One first aid. Coleman syndrome. It is in Coleman syndrome. Coleman syndrome is written in the all these reproductive disorders are written in the reproductive system. Okay. Failure Coleman syndrome. Failure to complete puberty. Our patient does not develop puberty. Defective migration of what? Neurons and subsequent failure of olfactory bulbs to develop, due to which when olfactory bulbs are defective, you are no longer be able to detect the smell. Okay, there is going to be anosmia. Okay, and along with that, there is decreased synthesis of GnRH, due to which you are going to see a hypogonadism. Okay, so what is the cause here? Coleman syndrome, and you are going to see decreased GnRH, and when GnRH is decreased, FSH LH is going to decrease. When FSH LH is decreased, testosterone is decreased, right? So at what point is affected? What point in this diagram is affected?
Hypothalamus.
A.
A is affected. Very good. A is affected. Okay. In hypothalamus, GnRH secretion is affected. Okay, and how does we come to the conclusion that it is called Coleman syndrome? Because the patient has anosmia, and anosmia is very specific for Coleman syndrome. Anosmia plus hypogonadism, Coleman syndrome. Okay.
Option.
Okay. 29-year-old woman increased hair loss, delivered a healthy baby 8 months ago. 8 months ago, remember this. Has not felt the same since. Has fatigued and decreased libido. Her fatigue, decreased libido, menstrual cycles have not returned. No prior medical problems and no drug allergies. There's no significant shows diffuse alopecia and thickened and brittle nails. That is hypothyroidism or hyper? Is it hypo or it is hypo?
Hypo.
Hypothyroidism.
Hypo. Okay, it is hypo. This is also is eliminated. Okay. Thyroid is non-tender. Thyroid is non-tender. That means decovariant is also eliminated. Okay, we are left with three options. Thyroid is non-tender, shows decreased serum TSH and decreased serum TSH is decreased. Okay, if it is Hashimoto thyroiditis and we are seeing hypothyroidism due to Hashimoto thyroiditis or postpartum thyroiditis, then what will happen to the TSH levels?
Will increase.
They are going to be high because the normal response of pituitary to low hypothyroid is to increase the TSH. But in this case, the TSH is also low. That means the diagnosis cannot be A or C. The diagnosis is secondary hypothyroidism. The main pathology is not in the thyroid gland, but it is in the pituitary gland. Okay. Okay. Cross section. So what do you can what people do you can what thing do you can see in this photo? Can anyone explain me this photo?
It's a cholesterol deposit.
Yeah, there is an atherosclerotic plaque here, which is most likely cholesterol plaque here. Okay, on in a 34-year-old patient. Okay, and her father died of an heart attack in an early age. Okay, poor. So he's telling us that it is linked to a genetic disease in which we are going to see early MI. Okay, early MI is seen in what genetic disease? Early MI in hyperlipidemia disorders. Okay, in hyperlipidemia disorders, we are going to see a early MI. Okay, assuming this patient disease had a genetic basis, poor respiratory expression is which of the following is most likely responsible for this condition? Okay, do you know in what type of hyperlipidemia we are seeing early MI?
Type 1.
In type 1, we see pancreatitis and hepatosplenomegaly, but not early MI.
Yes.
Okay. It is in
Type 2, yes.
type 2. Hyperlipidemia disorders. Accelerated atherosclerosis. Early MI before age 20. may have MI before age 20. In type 2, the main pathogenesis is defective on absent LDL receptors. LDL receptors are located at what organ?
Liver.
On the
Liver.
liver organ. Liver
Liver.
is the main one which is responsible for for removing the LDL. Okay. So if you have a absent LDL receptor, they are going to be the liver. Okay. The patient has large liver atherosclerosis.
Doctor, can you
Yes.
please explain the LDL receptors?
Okay, LDL receptors are located on the liver. They are responsible for removing the LDL from the bloodstream. The LDLs attach to the LDL receptors, and then the liver engulfs the LDL inside the cell and break down the cholesterol present in the LDLs. Okay, so the receptors are present where? On the LDL. Majority of the receptors of the LDL are present on the liver surface. Okay, and the liver is responsible for removing the LDL from the bloodstream. If the LDL is not removed from the bloodstream, you are going to see increased cholesterol, because the LDL main content is cholesterol. And when there is increased cholesterol in the bloodstream, you are going to see atherosclerosis and an early MI. Okay.
Okay.
Okay. Okay, the patient has 65-year-old man with benign prostatic hyperplasia for a follow-up treatment. The patient has obstructive urinary symptoms that were unrelieved with tamsulosin. Since starting, the patient has experienced. Okay. A new medication was prescribed at his last new visit 8 months ago. Okay. Since starting the new med, the patient experienced gradual improvement in urinary instance in strength of urinary. Okay, so that medication was prescribed for a benign prostatic hyperplasia. And after starting that medication, the symptoms have improved. Okay, the patient reports no pain or change in the glandular tissue. Okay, but after starting that medication, we are seeing a gynecomastia. Okay, so which medication can be a which medication has the side effect of gynecomastia? Okay, what is the cause of gynecomastia? When the estrogens are more than the testosterone, right? Patient will develop a gynecomastia when the estrogen is more than the a, when the estrogen is more than the androgen. Okay, if you block the androgen receptor, if you block the okay, now we have to find through which the estrogen is going to increase and testosterone is going to decrease. Okay. Okay, and that drug was used for benign prostatic hyperplasia. Okay. Increased prolactin production. Do you think option number E is the right answer?
No,
No.
because
Okay.
no. Yeah.
Option number C. Do you think option number C is the right answer? The drug was used for BPH, benign prostatic hyperplasia. Remember this.
No, no. That's
C is also not the right answer. We are left with A, B, and D. I have just told you that gynecomastia develops due to increased estrogen as compared to the testosterone. Do you know what drugs are used in benign prostatic hyperplasia?
Finasteride, 5-alpha reductase.
Finasteride is used. Okay. Does does finasteride block the androgen receptors?
No, it
No, it blocks the enzyme. It does not block
yes,
any
block the
receptors.
enzyme.
Okay.
5-alpha
Does
hydroxylase.
finasteride block the production of testosterone?
Yes. Conversion.
It blocks
Yes.
the conversion, not the production. It blocks the conversion of testosterone into dihydrotestosterone. Okay, it does not block the production of testosterone. It blocks the conversion of testosterone into dihydrotestosterone. Okay, there's a difference. Okay, so B is not the answer. So the only answer that is making sense here is D. Increased peripheral conversion of a testosterone to estradiol. And when estradiol is going to be higher, we are going to see because testosterone is not converting into DHT, right? When the testosterone is not longer converting into DHT, it is going to convert into something. Okay, and that something is estrogen. Okay, and the enzyme involved is aromatase. Okay. Which of the following laboratory findings are most likely present in this patient? Okay. First, try to make the diagnosis here. 19-year-old amenorrhea underwent menarche at 12. Her menses are irregular. Last menstrual period was 3 months ago. No significant medical history. Eats mainly fruits and vegetables. Exercise regularly. Exercise regularly. She eats only she eats only vegetables and exercise regularly. On further questioning, she expresses concern about being overweight and there is calorie restriction. There is the BMI is also less. The patient is thin, dry skin covered with fine downy hair. Diagnosis:
Anorexia nervosa.
the anorexia nervosa, and in this there is functional hypothalamic amenorrhea. Okay, this is the same question we just did 2-3 questions before.
Yes,
Okay,
yes.
and in functional hypothalamic amenorrhea, what will happen to the GnRH?
Will be
It will be
decreased.
low,
Decrease.
low,
And what if GnRH is less? What will happen to the FSH-LH?
also
Will
decrease,
also decrease.
Also
If
decreased.
FSH-LH is less, what will happen to the estradiol, estrogen?
also decrease.
Yes, this
Also decreased.
functional hypothalamic amenorrhea. Unintentional weight loss, fatigue, and sweating. Okay. No neck pain. No neck pain. D. Covariant thyroiditis is removed. E is not the answer because there is no neck pain, right? Unintentional weight loss, fatigue, and sweating. 2 months before that visit. 2 months before the visit, the patient the patient delivered a healthy baby. Okay, has no chronic medical condition, takes no medication. Blood pressure is 140/70. Pulse is 110. Expiration is 16. Mild diffuse enlargement of the thyroid gland, there is goiter there. Low serum TSH, elevated serum thyroxine, and triiodothyroid. Okay. Shows a mildly enlarged gland with decreased blood flow. Why there is decreased blood flow in this? Why the blood flow is decreased? Because it is showing that the thyroid cells are no longer working. Okay, if the cells are metabolically active, then the thyroid blood flow would be high, right? But the cells are not metabolically active. Okay, that's why the blood flow is decreased. Okay, what does that thing is telling us? Okay, if the cells are not metabolically active, then why there is high thyroxine? Why
Cells
there
are
is high
cells are
Cell
damaged.
destroyed.
Cells
Yes,
are
because
destroyed and the thyroid hormones are released.
yes, because the high thyroxine in this patient is due to thyroiditis. It is due to an inflammation which destroy the cells, and when the cells are destroyed, the thyroxine which is stored inside the cell is released into the bloodstream, and due to that stored thyroxine that is released into the bloodstream, that is causing the hyperthyroidism symptoms here. Okay, and that's why the cells on the thyroid ultrasounds are showing as low, are showing as depressed, as they have less metabolic activity. Okay, so what is the diagnosis here?
Postpartum thyroiditis,
Postpartum
Hashimoto.
Postpartum
thyroiditis.
thyroiditis, and the answer is
Release of performed thyroid
A.
hormones.
okay, release of preformed thyroid hormones. Okay, I think so. We should end this class here because I think so. I cannot, will not be able to continue it for long.
B also.
Okay. So 15 questions are left. We did almost 42 questions, 42 questions today, but 15 questions left. We will continue. We will end 15 questions tomorrow and start pharmacology and anatomy and physiology. Okay. After this.
All right. Thank you, doctor.
Okay, okay, but the ones which haven't still paid, please clear the dues. Okay, so we will able to continue with the class with the ones. Okay, please clear the dues. Okay, okay, bye bye.
Okay, bye. Thank you.
Doctor, thank you so much. I just wanted to ask
Thank
you,
you, doctor.
are the recorded videos, are you going to be sending them in the group?
Yes, it is. Sending the recording is the work of Dr. Hamza and Dr. Ahmed. I will ask them to send the recording to you. Okay. But
Okay.
for the recording, please leave the meeting immediately, because if the person does not leave the meeting immediately, the recording will keep on continuing. Okay.
Okay.
We can
Thank you
send
so
the
much.
recording only when everybody leaves the class. Okay. So bye bye. Okay. Bye.
Okay. Thank you.